So the diagnosis of lung cancer. One of the most frustrating things about lung cancer is a lot of people think you can only get lung cancer if you're smoking. And that really kind of makes me empathize for patients that certainly get lung cancer independent of smoking. And while lung cancer is known to be pretty aggressive in the sense that, it is hard to have long-term survival, we're realizing most of the reason is because of it almost sometimes being too late where it's already spreading. There's a couple of reasons for this, right? Like you don't have necessarily pain receptors in your lungs. And unless it's in a kind of fortunate position, which is a difficult word to use, you need some symptoms or signs to be able to find that cancer until it's caused a problem and grown to a certain size or started spreading, which is why screening is so important. And we're both very passionate about screening because smokers, for now, and hopefully one day the data will show more than that, but there's certain guidelines where CT screening with low-dose CT for lung cancer has shown a big improvement in survival because catching early is the key. So when you have lung cancer, or really any solid tumor cancer, surgery is always the optimal way to be cured for good. That is the gold standard kind of across the board, like a lot of solid tumors. You're going to have a collaboration between primarily your CT, your cardiothoracic surgeon. They're the person that can evaluate the patient, get an idea of the size of the lesion, the feasibility of, can we take this out and are you going to fare well without that portion of your lung? How much do we have to take out? And also, are we sure we're staged properly? Because the staging dictates if you want to do surgery first. Do you think survival will be better to reduce the size? And those are some of the things that you basically look at, right? When you have a new patient and they have either a biopsy or suspicious lesion, what is the kind of, flow about how to break into this subject?
So there are a lot of things that we look for when we have a new patient come in with a finding that's concerning for lung cancer. Typically, what's happened is the patient has gotten a CT scan, either because of an abnormal chest x-ray, because of a screen like you had mentioned, or most oftentimes the ones that we see are the ones that are incidental, meaning the patient had zero symptoms of any lung tumor growing, but they came into the emergency room with abdominal pain, or they came into the emergency room after a car accident and got a head-to-toe sort of scan and incidentally found a lung nodule. So the next step is to figure out, well, how concerned are we with that lung nodule? Some lung nodules are very, very small, and all we really need to do is follow them. We're finding something that was probably there for years and years and years. The patient just never realized it. Other scans are more concerning. So based on size, the shape of the tumor, if it's got a smooth wall or more jagged edges, all of those things give us a higher level of concern. And also the patient themselves, what's the age of the patient? Do they have a smoking history? Do they have a family history or other risk factors? So depending on our level of concern, we'll either order a biopsy or additional imaging, or if the finding is concerning enough, we'll just recommend going ahead and taking it out.
I'm glad you mentioned that. There are, of course, nodules and masses and lesions you can have in your lungs that aren't necessarily cancer. And
Absolutely.
We have pretty rigid guidelines, like you said, on knowing what looks suspicious, what doesn't, and what to do. But what we're going to go through is, and what you usually have, what's called a tumor board, is you have a group of doctors and specialists, your medical oncologist that does the chemotherapy, your surgeon that's going to be resecting the tumor, as well as radiation is a big part of kind
Absolutely.
of where lung cancer plays in. And we're going to go through kind of the things on how all of that is to determine what is the best way to keep this thing cured long term. That's why we do that and have that collaboration.
Absolutely. And it helps to have all of those different voices in the room to take the whole clinical picture into account, not just the scan, but also, the patient characteristics. What other medical problems does this patient have? Because that's all going to go into how we're going to approach that specific patient.
Yeah. And fortunately, a lot of stuff has come out where we're trying to be aggressive about not only having it taken out properly, but also therapies that happen afterwards to
Correct.
be able to say like, hey, this is a high chance of coming back and what can we do? So super excited to get into it. And, again, these things can be curable. We're hoping to really maximize the long-time survival.
Yes.
And it is a learning process. It's called practicing, but hopefully here you learn information to kind of really give you an idea of why the things are navigating the way they are and why it's so precise is, again, hopefully long-term cure and put a lot of attention into lung cancer.
Absolutely.